This talk for Adler Graduate School course number 504 is about the process of differentiating between two or more conditions that share similar signs or symptoms. The differential diagnostic process in mental health is a systematic approach to the distress of the client with the goal of identifying an appropriate DSM-5 and ICD-10 diagnosis or diagnoses. You will be describing the process of differential diagnosis in the case studies you complete for this course. The diagnosis is a key element of the diagnostic formulation, which, in turn, is part of the comprehensive case formulation. A DSM-ICD diagnosis is a categorical summary of the distress the client is experiencing at the time of the interview with the client. As we will see, there are also some diagnoses that are based on the experiences of the client in the past. There is a series of talks through the course on various aspects of the diagnostic formulation. The word diagnose comes from two Greek roots, dia, which means part, and nous, which means to know or to recognize. A description and classification system is a familiar concept across the sciences. It sets a foundation for research and for future developments. Consider the elements in chemistry or species in biology. In mental health, the diagnostic process focuses on clusters of symptoms and specific criteria defined in DSM-5. These criteria usually specify a time period, a number of related symptoms, and a frequency of occurrence of these symptoms in order to meet the diagnostic criteria. DSM-5 strives for a reliability in diagnosis, so that different clinicians will produce the same diagnosis after interviewing the same client. Now would be a good time to review the definition of a mental disorder on page 20 of DSM-5. I think of distress as being on a continuum, and when the distress has involved a certain number of symptoms and occurred for a specified amount of time, it can be summarized as meeting the diagnostic criteria. Not all distress can be described with a diagnosis, and a diagnosis can change over time. Differential diagnosis is a systematic approach to the distress of a client with the goal of identifying an appropriate diagnosis or diagnoses. For this course, you're going to learn two different approaches to differential diagnosis. The Morrison text presents a syndrome model and process in his book, and the DSM-5 handbook presents a symptom model and process. Any attempt to understand a person in distress begins by collecting information about the person. Usually, this database is built of information from several sources. In this course, you will be learning a semi-structured interview, the CFI, and a couple of measures, the Level 1 symptom measure and the HUDAS. There are many other interview formats and many other measures that are available. Another source of data is the records of the client, school, treatment, or hospitalization records. Many clinicians include a collateral interview with family or friends. A core component of your professional identity is a clear idea of what information you need to begin treatment. What questions will you ask your clients? What questionnaires will you administer and when? What records will you inquire about and obtain? When will you ask for contact with significant others to attain additional information? The DSM-5 Handbook of Differential Diagnosis is one of the textbooks for this course and is available online at www.psychiatryonline.org. The login instructions are in the online resources handout on the course page. This handbook defines a 6-step process that I call the symptom model and process of differential diagnosis. The first step is to evaluate if the client is making a good faith effort to report their symptoms. Next, consider the possibility that the symptoms are the result of drugs, of abuse, or of prescribed medications. This requires careful inquiry and an awareness of the side effects of many medications. Next, consider a general medical condition, especially if the mental health presentation is atypical in symptom pattern, age at onset, or course. With these etiologies ruled out, the next step is to identify the primary disorder or disorders. The diagnostic criteria in DSM-5 and the decision trees in Chapter 2 of the handbook serve as a guide for your diagnostic reasoning. I encourage you to make a diagnosis when you have clearly heard the criteria being met. If you don't know about a specific symptom or about the duration of symptoms, you can list your diagnosis as an other specified disorder and plan to inquire further with the client. Keep in mind that a diagnosis can evolve over time, not just because the client changes, but also because you gain more information. Once you have a diagnosis in mind, consider again the definition of a mental disorder: clinically significant disturbance of cognition, emotion regulation, or behavior, as well as clinically significant distress or impairment in social, occupational, or other important areas of functioning. There are no hard and fast rules about the boundary between distress and disorder. Clinically significant is based on your judgment and your understanding of the client. The Morrison text comes at the differential diagnostic process from a different angle. He aggregates signs and symptoms into familiar groups called syndromes. Table 3.2 on pages 20 and 21 help to generate possible diagnoses from the list of disorders and syndromes. He calls this list the differential diagnosis list. The list of possible diagnoses are organized into a safety hierarchy that places at the top those conditions that are most urgent to treat, are most likely to respond well to treatment, and have the best outcomes. This list is initially extensive and includes disorders that seem only remotely possible. The process of pruning and winnowing this list is completed using the diagnostic principles that are discussed in chapters 3, 4, 5, and 6 of the Morrison text. There is a document on the course page that summarizes these principles. Morrison describes his process of differential diagnosis for the case of Veronica in chapter 7. A diagnosis is a cluster of symptoms that have been found to occur together frequently. The DSM-5 defines a diagnosis with the number of symptoms present and a time duration for these symptoms. It is an attempt to create a category with rules that are external to the client. Having a category makes it possible to research the people who have satisfied the criteria for that category, and this research leads to empirically supported treatments. These are treatments that have been found to be effective with people who have met these criteria. This means that if your client meets the diagnostic criteria for a disorder, the empirically supported treatments for that disorder are likely to be effective with them. On the other hand, a problem list is specific to the client. You as the clinician may include items on the problem list. Clients frequently wish to ignore serious problems like substance abuse, self-harming behaviors, and other issues that, if ignored, can interfere with successful treatment. A good problem list includes counts or severity ratings for at least some of the problems, giving both you and the client a clearer picture of the problem. I like to work with the client in prioritizing the problem list, and I keep in mind the following questions as I participate in the discussion of priorities. First, is there a threat to life or limb of the client or of another person? There are some ethical and legal obligations we have to make this assessment and to act if we consider the risk to be high. There is another lecture in this course specifically dedicated to assessing suicidality. Second, do any problems undermine or jeopardize the therapy itself? These problems include agoraphobia so severe that the client cannot travel to the therapy session, or interpersonal problems that impede the client and therapist from working collaboratively together. Third, is there a problem that, if it is not solved, will prevent solution of any other problem? The most common problems of this type are substance abuse and living with an abusive partner. I have come to see non-restorative sleep as fitting into this category and have consistently urged clients to move this problem up the priority list. Fourth, what problem does the client have the biggest emotional commitment to solving? Considering this factor helps the client feel understood and respected, thus contributing to the working alliance. Finally, what problem is interfering most with the client's functioning? I had a client who identified not showering as a central reason she did not get out of the house, and when we focused on that, she was able to be more active in the community.